We welcome to the fourth virtual pediatric endocrinology for postgraduate session. We thank ISPE President and Secretary. Now I request our dynamic President Madam to start this session, Dr. Shaila Bhattacharya, Professor from Karnataka, Davangere. Over to you, Madam. Welcome you. We welcome all the attendees and to be interactive in the session, both you can unmute yourself and also in the chat box. First, there will be case presentation from Bhopal, Dr. Madhuri, and second case presentation is from the IGACH, Bengaluru. Over to you, madam.
Good evening, everybody. I think, Amarnath, we need to wait for some more time or what? There are only 9 attendees. Or else we'll start and... Do you want to wait for 5 minutes or shall we start?
Just we'll chit chat, madam, like that, and then I can explain.
We can wait for 5 minutes and then we can start.
Yeah, no issues.
Yeah.
How many attendees we actually expect, Dr. Ramannath?
Usually 52. Last time it was 100, sir. This time it is 4, maybe summer and all. Put in all the groups once again in the evening, just afternoon. So we can ask the Mayank, total how many attendees are there, Mayank? It's only panelist link, madam.
10, 11, 12 now.
Sir, give me 5 seconds, I will let you know.
There are
12. There are 12 right now. Attendees are 12, panelists 7.
Yes.
Now it's 13.
Okay.
13, yeah.
Again count to 12.
It's like the vote counting. BJP Congress का इधर उधर हो रहे हैं.
So till then, I will give. I will call Sudha madam just once.
How will you get to know in the YouTube? Can you see?
How many are watching it? 4 watching. It is live now, so watch it.
So, ma'am, looks like there will be some on the YouTube, is it?
There are 5 in the YouTube.
Okay, so we can conclude that 16 plus 5, 17 plus 5. Okay.
Shall we start?
Yes, madam.
Good evening, everybody. As Dr. Amarnath said, this is the 4th pediatric endocrinology for postgraduates series. This is to get more awareness for the postgraduates about endocrine problems. And today we have very exciting and also always students think it's a very complicated topic in endocrinology, that is congenital adrenal hyperplasia and atypical genitalia. For these two so-thought difficult topics, we have Dr. Rakesh from PGI and Dr. Sudha from Wadia, Mumbai, to discuss case and also to clear all the doubts which students have in their mind. So we will have the first case, and after the 2 case discussions, we will have OSCE about the same conditions. by Dr. Vani from Indira Gandhi, Bangalore. I think the case will be discussed after the history, one set of questions, then examination, one set of questions, and in between any questions are there, Dr. Rakesh will ask. And if the attendees have got any doubts, please put your queries in the chat box, whereas Dr. Panda and Madhuri can keep asking or answering the questions by Dr. Rakesh and Dr. Sudha. Over to you, Dr. Rakesh.
Thank you, ma'am. Thank you, Dr. Amarnath. Dr. Madhuri, could you start presenting?
Just 1 second, sir. I need to introduce. Now I request Dr. Madhuri Reddy, MD, postgraduate from AIIMS Bhopal, to present the case of congenital adrenal hyperplasia, and chief examiner will be Dr. Rakesh Kumar, professor. He is professor from PGH Chandigarh. Sir has got vast experience in DSD and other endocrinology disorders, and he is also editor for our journal. And also Dr. Sudha Rao Madam, she is professor from Wadia Hospital, Mumbai, and she will be also asking the questions to the both Madhuri Reddy and Dr. Panda. Over to you, Madam and Sir.
Thank you, Dr. Amarnath. Yeah, Dr. Madhuri, could you please start here?
Good evening, sir. Good evening, ma'am.
The audience can keep their questions ready, and they could ask, they would get that opportunity maybe in the chat box. Yeah, we'll be answering their questions once after history is completed, and then maybe after examination is completed, and after the full discussion again.
Is my screen visible, sir?
Yeah, but your voice is not that clear. Please be loud.
Yes, sir. Am I audible now, sir?
Yeah, that's fine.
Good evening, respected ma'am, respected sir. My name is
Madhuri, if possible, you can remove your mask and speak. It will be good. Thank you. Yeah.
Good evening, sir and ma'am. My name is Madhuri, and I'm a postgraduate from Department of Pediatrics, All Indian Institute of Medical Sciences, AIIMS Bhopal. Today I'm going to present the case. My clinical case consultant is Dr. Mahesh Maheshwari sir, and my moderator was Dr. Rakesh Kumar sir. Today I'm going to present details about a patient by name P, who is a twin, one out of two twins born, and his age was around 4 months 21 days as of day of examination 8/4/2022, and the date of birth was 20/11/21, and he was born at All Indian Institute of Medical Sciences, AIIMS Bhopal, and he was reared as a male, and he is a resident of Barkeda Patani, Bhopal. The chief complaints, as the baby presented to us at 4 months of age, if this 4-month-old baby who was reared as a male.
So, Dr. Madhuri, history was provided by the mother, and was she reliable?
Yes, sir,
and consistent? Okay, so that's important to say. All right, okay.
Presented with complaints of small penile length since birth, and passage of urine from under surface of penis since birth, and bluish discoloration of lips since 2 weeks of life. As we proceed with the history of presenting illness, it was the complaints of small penile length was present since birth. The mother is presenting his complaints, compared it to the other twin, that is twin 2, and it is also associated with presence of a deep groove in the middle of scrotum. The mother also complains that there was a while passing urine, the baby passes it from the undersurface of the penis since the birth, and it is also associated with the difficulty in maintaining the urine stream. These above mentioned complaints were not associated with any complaints of recurrent infections, irritability, vomiting, loose stools, lethargy, or excessive urination or excessive pigmentation of skin. child was apparently well till 2 weeks of age. From then, the mother also started to notice bluish discoloration of lips. On inquiry, she also happened to notice bluish discoloration of tongue. This was associated with complaints of failure to gain weight. She told these findings by comparing it with the other twin, that is twin 2. This history was not associated with any complaints of suppressed cycle, diaphoresis, fast breathing, or episodes of bluish spells on crying, or recurrent respiratory tract infections, or decreased activity or abnormal precordial activity felt by the mother, or any abnormal precordial bulge, and there were no complaints of any swelling of eyes, feet, or decreased urination.
Okay, can you stop on this slide, Dr. Madhuri?
Yes, sir.
So with these complaints, what do you think is the problem? What is medical analysis of this?
Sir, from the history, we can see that clearly the mother compares the penile length with the other twin. Most probably, it's a micropenis, most probably it's a micropenis, and it is a deep groove in the middle of the scrotum. Probably it can be a bifid scrotum, and if it is passage of urine from under surface, probably a hypospadiasis also, sir. And along with
hypospadiasis, small penile length, and looks like some bifid scrotum as well. So did you ask about the gonads, testis? What is the status of that's the first thing we would like to know, no?
Yes, sir.
So it may be all right to mention here that both testes were seen to be in the scrotum as per the mother. It's history right now. Obviously, we will examine it later, but immediately what would come to us in our mind, and which should come to our mind, would be the status of testes. Both testes being in the scrotum gives a lot of information to us that it is most likely XY.
Yes, sir.
Yeah.
Yes, sir.
Okay. All right. Carry on. That's fine. And obviously, second part is some cyanotic heart disease, most likely the way she is presenting.
Yes, sir.
About the bluish discoloration of lips. Okay, central cyanosis.
Yes, sir.
Since 2 weeks of age till 4 months. So it cannot be respiratory, most likely, because if it was respiratory, child would have been admitted, isn't it? And requiring oxygenation. All right. Okay. So we can think that it could be cardiac central cyanosis because of cardiac lesions. And for that, you have asked for the history to roll out left to right shunt or right to left shunt, or for that matter, cyanotic heart disease, cyanotic spells, etc. Okay. And features of CCF, if at all. Next, carry on, please.
In the family history, the child was born out of a non-consanguineous marriage. Here we can see that the firstborn was an 8-year-old female child. In between, the parents has terminated the pregnancy at around 2 months of gestation by taking the over-the-counter medication. And in the third pregnancy, here we can see there were 2 twins, out of which the first twin was a 4-month baby, and the second twin was male twin. In the family history, there were no significant complaints, no history of any similar complaints in the twin 2 or other family members, no history of any ambiguous genitalia, acne or hirsutism or voice changes in elder sibling or the mother during pregnancy, no history of any delayed puberty, amenorrhea or infertility or any corrective urogenital surgeries, and no history of any infant death in family. Whereas in the antenatal history, the age of the conception of the mother was 30 years. Pregnancy was confirmed by UPT at 2 months of amenorrhea, and there was no history of any acne, hirsutism, voice deepening, or clitoromegaly during the pregnancy. In the antenatal USG, they were provided some information that the twin 1 is having multiple congenital anomalies. The provided information was there were twins, and the first twin was associated with a congenital heart disease, probably they given it as a BSD, and a right-sided liver and a gallbladder noted on the left side, probably situs inversus. And no history of any gestational diabetes mellitus or hypertension or hypothyroidism. No history of any fever with rash. Adequate weight gain was noted during pregnancy. And in the perinatal history, a 30-year-old G3P1L1A1 mother delivered this dichorionic diamniotic twins via emergency LSCS due to preeclampsia at 35 plus 2 weeks of gestational age. Both the twins cried immediately after birth. Standard care was provided to them. Twin 2 was a male twin with birth weight of 2.1 kg and was shifted immediately to the mother side, whereas twin 1, our twin, was shifted to NICU in view of low birth weight, prematurity, and respiratory distress as history provided by the mother. And during his stay in the NICU, the parents were also informed of multiple congenital anomalies of the twin 1, and mother has been providing history that they also noted some atypical genitalia. In the developmental history, gross motor, fine motor, language, and social and adaptive are found to be normal. Whereas in the immunization history, he received immunization till date as per NIS. Last received vaccination was of 14 weeks. In the nutritional history, he is breastfed along with formula feeding by Katori and spoon since birth. Frequency of feeding is every 2 to 3 hourly. If we look at the calorie intake, he is taking enough calories required for his age. That is required is 387 kilocalories per day, whereas he is taking 440 kilocalories. In the protein, he is taking 8.3 grams when required, out of which required was only 5.1 gram per day. The socio-economic status, as per modified Kupaswamy classification, it comes to be a lower middle class family. Whereas if we go into the past medical history, he was admitted after birth for the respiratory distress and prematurity. He was worked up for this atypical genitalia and some congenital heart disease and for internal malformations as they were documented accordingly in the antenatal sonography. And he during his course in NICU, investigations for all these malformations was continued, which was noted in the antenatal USG, and during discharge, he was started on some regular oral medications in the form of tablets, as history provided to the mother. At the end of the summary, at the end of the history, the summary is a 4-month-old child who is reared as a male, second born as twin 1 out of non-consanguineous marriage, developmentally normal, fully immunized, presented to us with complaints of bluish discoloration of lips and the tip of the tongue, probably central cyanosis, along with failure to gain weight and atypical genitalia without any features suggestive of salt wasting or hyperpigmentation.
So Dr. Madhuri, with this history, how do you analyze it and what are the likely possibilities or differential diagnosis?
Sir, here, according to the complaint she has provided us, the baby might be probably having some micropenis or along with the hypospadiasis, sir, along with some congenital heart disease. Regarding the atypical genitalia here, based on the complaints, we are getting to know probably that there might be some under-virilization in the male, and it was not associated with any history of regarding salt wasting, sir, or hypocortisolism. So as of now, with this history, I'm considering some disorder which might be related with androgen production of problems related to production of androgen or androgen synthesis or action related issues, sir. Whereas regarding congenital heart disease, the mother has clearly told that she noted observing this central cyanosis from around 2 weeks of life, and they were not associated with any recurrent episodes of lower respiratory tract infection, which indicates that there is a reduced pulmonary blood flow. So probably that this cyanotic congenital heart disease with the reduced pulmonary blood flow, we can suspect some disorder with tetralogy of Fallot type physiology, sir.
Okay, so and there is some suggestion of liver on the left side and situs inversus abdominal, isn't it? So can you think of some unifying diagnosis?
Sir, as of now,
okay. So you are presuming that there, I think mother has told you that there were testes were both palpable, testes were there in the scrotum as per mother, isn't it?
Yes, sir. She can.
So that's why you are thinking it to be XY DSD and disorder of androgen synthesis or action.
Yes, sir.
With regards to its DSD or under-virilization, that's fine. What if I give you a hypothetical situation that there were no testes palpable? No gonads palpable. So what would be your immediate possibility and what would be your immediate action? You are seeing this baby at 4 months.
Yes, sir.
And there is small phallus, very hypospadias as mother is explaining it to be.
Yes, sir.
But there are no gonads. What should be your immediate possibility?
Sir,
and what should be your immediate action without gonads palpable?
Yes, sir. Without palpable gonads, we can suspect it to be a 46 excess DSD, and with such amount of virilization, we should probably be first thinking about 21 hydroxylase deficiency, sir.
Okay. So yeah, so in that case, maybe we'll see some. There would be some features of adrenal insufficiency, if at all. If it was severe form, obviously by 4 months there would be some symptoms or signs of and hospitalization because of adrenal insufficiency, and we should immediately rule out 21 hydroxylase deficiency. Yeah. Okay. Next, we can move on further.
Now I'm proceeding with the examination. This baby, as of admitted, he was of the baby was of 4.5 months of age. And in the examination, the child was active and playful. Central cyanosis was present, and among vitals, pulse rate was 130 beats per minute with regular rhythm, good volume, and no radioradial or radiofemoral delay, with a respiratory rate of 34 beats per minute, regular in rhythm, and abdominal thoracic type of respiration. Among saturation, 56% was noted on the room air. Among the 4 limb saturation, we have noted all of them ranged between 56% to 58%, and even with hyperoxia test, even with 100% oxygen supplementation for a minimum of 10 minutes, the saturation did not go above 66%. And then the blood pressures were noted in the right upper arm in the lying position using manual BP meter. Then it was 75 by 46 mm of Hg. It was interpreted as between 50th to 90th centile for the age and gender. And capillary refill time was less than 3 seconds, and temperature was 98.3 degrees Fahrenheit. RBS was found out to be 107 mg per dl, and no paler icterus or clubbing or lymphadenopathy was noted in the examination.
What is hyperoxia test? How did you do it?
Sir, in hyperoxia test is usually done in order to differentiate the causes of the cyanosis, that is central from the respiratory to cardiac causes, sir. With the usually in respiratory causes, with the supplementation of oxygen, there will be rise in the SpO2, sir. But normalization of SpO2 can be noted. But whereas in cardiac defects, even after supplementation of oxygen, like 100% FiO2 provided at least for a minimum of 10 minutes would not normalize the saturation in cardiac defects, sir.
Okay, what else will be there in respiratory causes of central cyanosis? What else you expect? So obviously there should be significant respiratory distress. The respiratory rate here is 34. You have not documented any, no retractions, nothing, no accessory muscle, respiratory muscle use. Yes. What is the importance of checking SpO2 in all 4 limbs?
By noting it in all the 4 limbs, we can know the differential cyanosis, sir. That is because of the ductal shunting.
What conditions will have differential cyanosis?
Duct-based systemic circulation disorders will have these differential cyanosis, sir.
All right. Okay, we'll move on. Next. So there are no features of any hypotension, shock, anything. Yeah, obviously. Next.
When the examination is continued on head to toe examination, hair was normal in appearance and texture. Cranium shape and size appears to be normal. No obvious facial dysmorphism were noted. No hyperpigmentation of skin or genitalia were noted. Eyes, ears, and nose appears to be normal. Oral cavity was normal. No cleft lip or palate were noted. Hand, feet, and limbs appear normal. The skin and genitalia, skin and nails appear normal. No hyperpigmentation was noted in the skin, and no neurocutaneous markers.
So in this particular child, why you are worried about hyperpigmentation? Why are you looking for that?
Sir, hyperpigment, if there is reduced adrenal steroid synthesis, there will be increased ACTH secretion. The increased ACTH will lead to hyperpigmentation, sir.
Okay, so all right. So if there is CAH, you may get hyperpigmentation. So what form of CAH you would expect in this child? XY DSD.
Yeah, as of now, I will expect only a simple virilizing form, sir. Nice.
So and any other form of CAH which
nice.
can present with hyperpigmentation and XY DSD?
Sir, yes, sir. Like hyperpigmentation, I'm sorry, sir. Hyperpigmentation and XYDSD, there can be proximal steroidosynthetic defects like 3-beta HS2 deficiencies, star deficiencies, or just side chain cleavage deficiencies. These can be suspected if there is associated hyperpigmentation along with the undervirilization in this patient, sir.
Oh yeah, so we need to remember that there are some forms of CAH which would present with, although rare or uncommon, which could present with XYDSD. Yeah, most common form of CAH, obviously 21 hydroxylase deficiency, will not have DSD in boys or will not have undervirilization in boys. Yeah, okay, next. Carry on.
On anthropometry, we have done the anthropometry according to the corrected gestational age. Weight, see, among the interpretations.
You mean post-conceptional age? Yeah,
yes,
you mean post-conceptional age, corrected age. Okay, because this child was a premature. All right. So we have to correct this age till what age?
40 weeks of gestation.
Lifelong?
No, sir. 40 weeks of gestational age tak we did correction until 2 years of age, sir.
So correction for these parameters to see for the appropriateness of weight, height, and other parameters, we have to correct till 2 years.
Yes, sir.
So by 2 years, we expect that catch-up will happen. Yeah. All right. Okay. Next.
Among
so this baby had
severe underweight, moderate stunting, along with moderate wasting was noted among the anthropometry, sir.
Okay.
Among genital examination, bilateral testes were palpable in the scrotum. The volume of the testes was noted to be 1 ml on both of them, and stretched penile length was noted to be 1.8 centimeter with ventral cardi. Single urogenital opening was noted. Urethral opening was present on the ventral surface of penis at mid-shaft level, and bifid scrotum with normal pigmentation and rugae were noted. Here, I have done. We have mentioned the external.
What would be normal or average penile length in newborn boy?
Sir, anything less than 2 to 2.5 centimeter will be considered as micropenis, sir.
2 or 2.5 or something else? So cutoff will be some one value, no? It cannot be range.
Yes, sir. Less than 2.
So average will be 2.5 and cutoff maybe 2
yes.
or 1.9. Okay. But yes, I mean, it will vary from race to race. So we need to have Indian data on this. And the data is available actually. Okay.
Right. Just 1 second, sir. Dr. Harish answered the 2.5 centimeter. Previously also he answered the causes of the differential cyanosis is PDA with bisulfingration. We expect all the candidates to participate actively. So please note, it is for all people, not only for Madhuri. Thank you. Go ahead.
Yeah, carry on, Madhuri. Yeah.
Yes, sir. In the genital examination, among the external masculization score we have done, it was a total out of 4 out of the 12. Scrotal fusion was 0. Micropenis, yes, 0. Urethral meatus was at the mid shaft, and bilateral testis were in the scrotum, hence given a score of 1.5, 1.5, both of 3. 4 out of 12 was scored.
So now, do you know any other score which is practically used for, say, this score is for undervirilization in XYDSD, yes, or undervirilization in boys to yes, objectively quantify how much undervirilization. Okay. So you know some score which is used for virilization in girls?
Yes, sir. Prader score is used for virilization in girls, sir.
Okay, but the problem is when we are not sure whether it is XY DSD or XX DSD, So which score we should use? So when it is real ambiguous, in this case, it is not that ambiguous. We know testes are there in the scrotum, isn't it?
Yes, sir.
So when we are not sure which score we should use. So maybe we'll have to use both. Okay, so there is no definite answer to it, but so this is the problem with these two scores actually. So one is female specific or for XX DSD, and other is X for XY DSD. So, but because there is ambiguity in genitalia, we are not sure which score we should apply. So there is this is limitation of both these scores, and now another score actually has been developed. It's called external genitalia score, EGS. So it is gender neutral scoring system to see. So obviously the scoring will be like that. It will tell us that how abnormal is the genitalia, how ambiguous is the genitalia, and it is towards male or it is towards female. So maybe you can go through that. Obviously, for the sake of time, we can't. It is called external genitalia score. It has recently been developed and in fact validated sometime in 2017, and later it has appeared. Okay, next.
And among the systemic examination, first we will go for the cardiovascular system examination. In the inspection of the precardium, no hyperdynamic precardium was noted, no precardial bulge was noted, no asymmetry of the chest or visible pulsation or venous prominences were noted. On inspection, the apex beat was found to be in the fourth left intercostal space, 0.5 centimeters lateral to the midclavicular line. On the palpation, we have confirmed the position of the apex beat, that is in the fourth left intercostal space, 0.5 centimeters lateral to the midclavicular line. No precardial or epigastric or suprasternal pulsations were noted, and no thriller parasternal heave were noted. Whereas in the auscultation, S1 was heard as normal, and single.
Dr. Madhuri, for the sake of time, just tell us the positive findings. So in CVS, rest of the examination was normal. Child had grade 3 mid-systolic murmur, and it was normal position of the heart, because there we are thinking of some situs inversus as well, as per the suggestion in the antenatal ultrasound. So
yes, as per the examination, I found it to have be levocardial.
Normal position of the apex beat. Okay.
Yeah, all right, with central cyanosis. Yeah.
Next.
And in the abdominal examination and in the inspection shape, no obvious swelling was noted or distinction.
Please don't repeat, read out. Just tell the positive findings.
No positive findings were noted in the abdominal examination, sir.
But you have to specify where was the liver palpable.
Sir, in this kid, we did not get any organomegaly, or we did not get any palpation of liver below the costal margin, sir.
Either on the right or the left.
Yes, sir.
That's what you are saying?
Yes, sir.
Okay. So normally at 4 months of age, we should have liver palpable, no? Around 1 to 2 centimeters maybe. They have small, their abdominal muscle tone is quite less, and we can easily palpate the internal organs. Sometimes even spleen can be palpable, a tip of it or something. So you could not palpate liver. I don't know it is normal or abnormal. So there may be some, it may have some relevance here in this case. Okay. All right. Next.
And in the respiratory system examination, nothing came abnormal out of the inspection, palpation, or percussion or auscultation. Whereas in the central nervous system examination also, no gross abnormalities were detected. And at the end of, now I'm providing the summary with the at the end of the history plus examination. A 4-month-old child, reared as male, second born as twin one of non-consanguineous marriage, developmentally normal, fully immunized, presented with complaints of central cyanosis, along with the failure to thrive and atypical genitalia, without any features suggestive of salt wasting or hyperpigmentation. On examination, was found to have a cyanotic congenital heart disease with reduced pulmonary blood flow, along with failure to thrive, with micropenis, with hypospadiasis, with bifid scrotum, and with bilateral testes palpable in the scrotum.
Okay, so any questions from the, I can't see any questions in the chat box. If the residents want to have more information about the patient and have more suggestions about the differential diagnosis for this child.
If anybody wants to talk, they can raise hand and we can unmute. Yeah, Shrestha, you have any points to tell? Dr. Shrestha?
No, sir.
Okay, so Dr. Madhuri, can you Now, after history and examination, what are your possible diagnosis, differential diagnosis or diagnosis?
So even with the examination of the external genitalia, we have confirmed the under-virilization of this baby, sir. As the bilateral testes are palpable in the scrotum, obviously.
So
it is
XY DSD is clear. Okay.
Yes,
We can call this child as XY DSD. When do we call? Should we call this child to have DSD or not?
Yes, sir, we can call because he's clearly having a bifid scrotum and hypospadias and microspadias. Atypical genitalia are present, sir.
So when do we don't call it DSD in a boy? So if it is distal hypospadias with no other abnormalities, it is not DSD. Okay.
We do not evaluate
So when it is single undescended testis,
it's an asymmetric genitalia, mostly mixed gonadal dysgenesis or ovotesticular.
No. My question here is what are the abnormalities in genitalia which in a male which do not qualify for DSD? Means they don't need to be investigated for DSD. In boys, what are the lesions in the genitalia or abnormalities whom we don't need to investigate or we don't label them as DSD or ambiguous genitalia?
One thing is like distal hypospadias, sir.
Yeah, isolated distal hypospadias, isolated unilateral undescended testis. And if rest all is fine, but undescended testis with micropenis, yes, we have to investigate. If there is combination of two minor abnormalities also, we'll have to. But any proximal hypospadias obviously has to be investigated, even if it is isolated.
Yes.
Both testis undescended, it has to be investigated and labeled to be as. So obviously there could be some confusion sometimes. So this scoring system actually helps. So the score which you told, EMS. So what is the cutoff? That score, if it is less than that number, we have to label the child as DSD and investigate. What is that cutoff? What is the total score in EMS?
12, sir.
12. So
Yes.
What score will qualify for DSD or investigation? So this child had 4, isn't it? You told 4. Total score was 4.
Yes, sir.
So obviously this is far ambiguous, or this child will have to be investigated. So any score less than 11. So any score less than 11 will be labeled as low, or our child will have to be labeled as DSD. Okay, move on. So give your differential diagnosis after history and examination. Yeah.
Even at the end of the history and examination, sir, we have found that it is an XY disorder of sexual development, probably XY DSD, with under-virilization, without any features suggestive of any salt wasting or hyperpigmentation was not there. And but hence I'm considering now also I'm considering disorders that are associated with androgen synthesis or action-related problems, probably like 17 beta HSG2 deficiencies or partial androgen insensitivity syndromes or 5-alpha reductase deficiencies.
Along with congenital cyanotic heart disease, along with some situs inversus suggestion in that, we have not yet investigated this child, obviously.
Yes,
so it has to be most likely some syndrome, no?
Yes, sir.
So there are multiple systems involved, multiple anomalies there. So it has to be some syndrome. And DSD should be part of the syndrome, most likely, because we cannot give different diagnosis for each presentation in this child. So we have to have, as the clinical dictum goes, we should explain all the findings with one unifying diagnosis. And that could be some congenital genetic syndrome, which obviously will be characterized after a lot of investigations and workup. It may not be possible straight after history and examination. Yeah. So we will move on further.
Hence, at the end of the history and examination, we have reached a diagnosis of dichorionic diamniotic twin 1, cyanotic congenital heart disease with reduced pulmonary blood flow, probably of the top physiology, with abdominal situs inversus with levocardia, probably of isolated levocardia, with a disorder of sexual development, probably of XODSD, mostly a syndromic cause was suspected, and As congenital adrenal hyperplasia are most commonly seen among the disorders of sexual development, we have planned to rule out this as the cause for the disorder of sexual development.
Yeah, so it is always important to rule out CAH even in under-virilized males, because that is one serious condition which we don't want to miss. Although the possibility here looks less with the overall profile of this child, because he never had any problems till 4 months of age. And under-virilization is not explained by the common forms of CAH like 21 hydroxylase or 11 beta even. Okay.
Dr. Harshini raised the hand. Just 1 second, sir. Dr. Harshini, you want to tell anything? Just go back. Dr. Harshini, you raised the hand. Okay.
She could write in the chat box if she wants. It's okay.
Yeah. You can write in the chat box. Yeah, go ahead. Thank you.
So hence in the differential diagnosis, we have initially considered the disorders that are associated with the as his till examination and history, we have found it only under-virilization of this baby, and no other salt wasting related history was provided. Hence, we have considered initially the disorders of androgen synthesis or action, primarily partial androgen synthesis, 5-alpha reductase deficiencies or 17-beta HSD. And after that, we have also kept possibilities of salt wasting syndrome, which might present a later age with mild salt wasting, like other disorders like 17-beta hydroxylase, 3-beta HS2, POR deficiencies or side chain cleavage deficiencies or star deficiencies.
So it's all right to list all this. Can you go back to the previous slide, please? So it's all right to list all these possibilities, but I personally feel strongly that in this child, this genitalia malformations could be part of the overall syndrome. So many genetic syndromes usually will have hypospadias or maybe small penis or something. So just because this child has many other congenital malformations, internal and external. So we may not have hormonal cause of DSD in this child, or in many children for that matter, who have multiple anomalies. So that also option has to be open. But yes, for theoretical discussion, these are the possibilities which we have to consider in a child, in a boy with under-virilization. Yeah, next.
Now we'll look at the investigations. As the child was admitted in NICU initially, where atypical genitalia was noted, certain investigations were done at the birth. Among them, the serum electrolytes, they were done in day 3 of life. They were found to be sodium 132 and potassium 7.05. As salt wasting was present, 17-hydroxyprogesterone levels was done for to detect the congenital adrenal hyperplasia related disorders. It was found to be very, very high. That is 212.5 nanogram per ml level was found on it, but it was done in the day 3 of life. After this, child was started immediately because of this salt wasting pattern, along with the very high levels of 17-hydroxyprogesterone. Child was started immediately on hydrocortisone and fludrocortisone from the day 4. Karyotyping was done in order to confirm our suspicion of 46XY-DSD, and the karyotyping came out to be 46XY. And the serum cortisol and ACTH levels were done in order to know the hypocortisolism, that is reduced adrenal steroid synthesis along with the salt wasting, but they were found to be in the normal values.
Dr. Madhuri, I think the normal range you have written is not correct. It should be nanogram per ml, not DL.
Sorry, sir.
Okay, so 212 nanogram per ml is quite high actually. So here is the surprise for us. This child actually on day 3 had salt wasting.
Yes, sir.
Isn't it? And all through the history, we could not detect that.
Yes,
obviously,
sir.
mother may not be knowing. She will not come up with a history. This baby was admitted for respiratory distress, and
yes,
it is
sir.
at that time they could document, the NICU team could document hyponatremia and hyperkalemia, isn't it? So
yes,
there
sir.
is salt wasting, which was documented at day 3 itself, very early in the course.
Yes, sir.
That actually suggests a severe form of CAH if it is there. Usually, commonly the CAH will present in 2nd, 3rd week with salt wasting. So can you tell the reason for that?
Because of maternal steroids passed on to the baby while it was in the intrauterine life, it takes some time for them to wean off and present with salt wasting, sir.
And 17 OHP is 212 nanogram per ml. Serum cortisol obviously at that stress looks
Yes.
quite low. 182 is actually low if it was done at a sodium of 132 and potassium of 7 and child was having respiratory distress. So we have to
Yes.
see the physiological status of the child. 182 is quite low for a child who is in severe stress, isn't it?
Yes, sir.
So this is cortisol is actually its interpretation is that this is low actually given the physiological status of the child. So karyotype is good that as expected it is 46XY. So how do you interpret the sodium, potassium, cortisol, 17 OHP? What is the likely possibility now with these investigations?
With these
front of you.
investigations, with the serum electrolytes, clearly there is salt wasting. Further stress of the baby with the cyanotic heart disease and along with the respiratory distress serum. If we consider the serum cortisol levels as to be low, then clearly the adrenal steroids are not reduced. Synthesis of the adrenal steroids is clearly reduced, and the 17-hydroxyprogesterone levels, they are very, very high. We can only with these investigations we can consider 21 hydroxylase deficiency, sir. But our child, as he's a male, confirmed male with undervirilization, 21 hydroxylase deficiencies usually does not have undervirilizations in males, sir. That's what.
So that's the usual scenario. So investigations are pointing to one diagnosis, but clinically it is not fitting. So 21 hydroxylase deficiency. Why should the boy have undervirilization? So that's a problem. So things are not matching here. So that's a usual story actually. So things don't go as we expect. So we'll have to work more on this, it means. Next, carry on. And obviously with these investigation reports, we cannot not give hydrocortisone and fludrocortisone. So they have to be started. So it was rightly started. So hydrocortisone and fludrocortisone, which mother told that some tablets were started on long-term basis. So these must be hydrocortisone and fludrocortisone.
Yes.
Yeah. So in that case, looks like this child was already on hydrocort and fludrocort, and that's why this child did not go into further salt wasting or crisis over next 3-4 months. So that could explain still that there could be CAH, but because child was started on physiological replacement of steroids, he did not have any adrenal crisis. And maybe 3-4 months is too short a time to look for another episode of adrenal crisis, particularly when child has been started on replacement on day 4 itself. Okay, so still CAH possibility would be there, but let's see how it proceeds. Yeah, next.
Radiological investigations that were provided at birth were chest X-ray and 2D echo. This was chest X-ray done on day 1 of life. Here we can see cardiac apex is on the left side, along with the upturned right apex, along with oligemic lung fields, along with probably a stomach bubble-like structure noted on the right side of right hypochondrium, and liver-like structure. As antenatally USG also, it was suggested that liver was on the left hypochondrium. Here we can see the structure. In the 2D echo, we in the 2D echo evaluation for the respiratory distress without any problem related to the lung related problems. So we have gone for the 2D echo immediately, and it showed us a double outlet right ventricle with large subaortic VSD with the severe pulmonary stenosis with patent ductus arteriosus. And then after this, once the baby was started on for hydrocortisone and fludrocortisone on day 4 of life, after some time the parents has to left the college against hospital against medical advice, and once again they have reviewed back at they had review back at 4.5 months of age. During the antenatal during the perinatal period, they were for the confirmation of the disorder, probably because of the high 17-hydroxyprogesterone levels, we have sent next generation sequencing for 21 hydroxylase deficiency, which came out with this report, which was negative. They came once again visited hospital at around 4.5 months of age. That is this admission of the child. During this admission, our evaluation showed that the serum these investigations were on medication when the child was currently on the hydrocortisone and fludrocortisone. Here we can see that the serum electrolytes at 4 months of age, the sodium was 135 and the potassium was 5.27, whereas the 17-hydroxyprogesterone levels on the treatment were very, very low, that 0.31 nanogram per ml, and Androstenedione, it was for the under-virilization, we have gone for the gonadal steroid, that is androstenedione was found to be 3 nanogram per ml, and the testosterone was 41.88, which was normal, and 5-alpha dihydrotestosterone was 7 nanogram per deciliter. As the age of 4.5 months was around to be expected to be in the mini puberty, we also planned for a LHS and FSH, but could not be done in order to prove the mini puberty, but could not be done because of financial issues of the father. The ratio of the testosterone to androstenedione was 13.98, and the ratio of the testosterone to dihydrotestosterone was 5.85, which are normal. And we have gone for further investigations to look for internal anomalies. That is, USG abdomen showed liver more towards left hypochondrium, and stomach bubble was seen in right hypochondrium. And a well-defined oval homogeneous echogenic soft tissue was noted in the right hypochondrium, likely to be a spleen. And bilateral kidneys appear to be normal. Left adrenal gland appears normal, and right adrenal gland was not visualized in the sonography. Whereas to look for other internal anomalies, transcontinental USG was done, which showed an enlarged cisterna magna extending anteriorly with the cerebellar vermis aplasia or hypoplasia, and the USG pelvis was done to look for the Mullerian structures. No Mullerian structures were noted. Impression of this sonography was mostly suggestive of a situs inversus with levocardia with megacisterna magna and cerebellar vermis hypoplasia. Based on these investigations, we have come to a diagnosis that it is a dichorionic diamniotic twin bone with isolated levocardia, that is cyanotic congenital heart disease, DORB with PS with VSD with disorder of sexual development, probably congenital adrenal hyperplasia secondary to 3-beta HSD deficiency.
Okay, is that your final slide?
Yes, sir.
Okay. So I think there are other experts as well. Dr. Sudha Rao, Dr. Shaila, Dr. Amarnath, if you can please chip in and
Thank you.
Suggestions about the case.
Yeah, thank you very much, Dr. Madhuri Reddy and Rakesh sir. Discussion was excellent. And Dr. Himmat, he wrote in the chat box that he wanted to do microarray for the multiple anomalies for the genetic problem. So now I request Dr. Sudha Rao, madam, any comments or any questions for the Madhuri Reddy?
Ma'am, she will have to unmute. Ma'am, if you have to. Ma'am is muted.
Okay.
All right. Dr. Shaila is there. So if not, any questions from the...
one or two suggestions from my side, sir. So all pediatricians and pediatric postgraduates, any child with dehydration or vomiting, kindly expose the genitalia and look for the bilateral undescended testis and micropenis or hypospadias. This will save you a lot. We have seen cases at age of 6 years, 8 years, undescended testis, or even for the CAH. So even you can diagnose the enlarged penis and virilization or the pubarchy. All those things can be detected early. Second thing, always monitor the growth, very, very important. Third thing, look for the pubertal signs in all the child. Some DSDs can present later, that will be covered in our ASCII. Over to Shaila madam.
Yeah, I would agree with most of the things whatever Dr. Amarnath said, but it's not only when the child is having hyponatremia, hyperkalemia, you have to check the genitalia. I think every child who comes to your clinic, whether it is a male or a female, you have to check the genitalia is one of the systemic examination. So every child should have examination done, because we see children who are at 10 years and parents are not sure whether they have seen any time testis or not. Even at 10 years, we find missing testis. So we don't know where we are. So I think you should keep an habit of testing, undressing the child. Even I know all the PGs will examine without even opening the clothes for the respiratory examination. So I think you should learn, because many things, the skeletal deformities, scoliosis, pectus excavatum, all or carinatum, lot of things can be missed if you don't undress the child. And you should be happy that you can undress the child. If it is an adult patient, you can't do that. So you should always undress and examine thoroughly, including the genitalia. And Dr. Rakesh has already discussed most of the things about how you should suspect. So any child who has hyponatremia, hyperkalemia, immediately you should think first thing, simple gastroenteritis. Second is always congenital adrenal hyperplasia, especially again if the blood sugar is low, blood pressure is low. I think it's nothing other than CH. Even in the remotest place, you need to take one sample to send it later on, which we call as critical sample, and go ahead with the treatment for the child. Thank you.
Yeah, Dr. Amarnath, how much time I have? Maybe 10-15 minutes will be okay.
Yes, sir. Yes, sir. Go ahead, sir. Thank you very much, madam. Over to Rakesh, sir.
So just a brief presentation which I prepared for the PGs, just some tidbits for CAH for them. So I think to put things into perspective, they should know about his approximate incidence or occurrence of CAH. I think most of us know the incidence of congenital hypothyroidism, around 1 in 2 to 3,000 in India, and even more in some places. So it is almost double of that. So CAH incidence is, you can remember that way, it's 1 in 6,000 if we combine all forms of CAH. So it's around 1 in 7,000 if we think of 21 hydroxylase deficiency, or classic one. And salt and simple virilizing, it would be around 1 in 20,000. It's quite uncommon, obviously. And most common CAH we know is CYP21A2, and which accounts for nearly 95% of all forms of CAH. So for postgraduates, I think we should discuss under these headings what is important in history if you are examining a child with suspected CAH. History examination, what investigations. So when do we suspect CAH in a newborn? So in the history, if there are unexplained SIP deaths, virilization or atypical genitalia in the previous SIPs, consanguinity is very important. Most of the CAH are autosomal recessive. Family history of DSD or infertility for that matter, particularly for XY DSD, if we are evaluating, it may not only CAH, but other forms of DSD could also present like this. So any history of intake of antenatal progesterone by the mother can cause undervirilization in boys. Atypical genitalia at birth, around 2 to 3 weeks, vomiting and poor weight gain, that would be typical presentation of CAH in girls. Maternal drug intake, antenatally, it's important history. And maternal virilization during antenatal period is another cause of virilization in the female babies. So on examination, what you should not be missing is documenting ambiguous genitalia. And how do we examine it? Maybe some part has been clarified for XY DSD. What are the steps to examine? What all important findings ought to be documented, and we should be as objective as possible. And these scoring systems help in that. So hyperpigmentation, we have to be documented, and adrenal crisis, neonatal sepsis with shock. I mean, adrenal crisis may be confused with, or usually it is commonly labeled as neonatal sepsis with shock or acute gastroenteritis with dehydration or something. So we should always be, both these conditions will not have hyperkalemia. They would normally have hypokalemia, the gastroenteritis, sepsis, shock, and all that. So poor weight gain is another weight has to be documented in examination. So dehydration. So important trick here is in dehydration in these children will have polyuria or normal urine output. All other forms of dehydration would have decreased urine output. So like diabetes, diabetic ketoacidosis, there is dehydration along with polyuria or normal urine output, so-called. Even in CAH, because of sodium loss in the urine, they will have normal urine output or polyuria, and there will be no history of decreased urine output. So that could be one simple historical point which we can ask. So dysmorphism could be there. We have to examine for dysmorphism. There are many syndromes associated with CAH, and obviously genitourinary abnormalities have to be, other abnormalities have to be checked for. So basic lab investigation which will give us clue about the CAH would be sodium potassium acidosis and ultrasound pelvis. If there are no testes and Mullerian structures are there in an apparent male or reared as male, so we should think of CAH or 21 hydroxylase deficiency in that case, in XX DSD. So common differential diagnosis in newborn period, particularly with normal genitalia, obviously. So these children will be labeled as either neonatal sepsis, acute gastroenteritis, congenital pyloric stenosis, failure to thrive, and persistent vomiting could be featured for CAH as well, and which is common for pyloric stenosis as well. But these three conditions will have hypokalemia, but CAH has hyperkalemia. So that's one important differentiating point. With simple sodium potassium levels, we can pick it up. So congenital adrenal hypoplasia could also present like this with normal genitalia. They will have low cortisol and everything, but not hyperplasia in that case. So congenital hypoaldosteronism, aldosterone synthase deficiency, again will present with salt wasting. And similarly, pseudo-hypoaldosteronism secondary to UTI or genitourinary malformation, particularly hydrouteronephrosis children with UTI, they can have pseudo-hypoaldosteronism, or otherwise pseudo-hypoaldosteronism is a syndromic diagnosis. So these are the differential diagnosis in newborn period, but they will have normal genitalia. Some forms of CAH will also have normal genitalia. So when to suspect CAH in older child? So this was the case discussed was a newborn or an infant. So in older child, the CAH may present as simple virilizing form, will present only with virilization, say at 2, 3, 4, 5 years of age. Peripheral precocious puberty, again, part of virilization. Hypertension, they may present with hypertension, the 17 alpha and 11 beta forms of CAH. Earlier excessive pubic, facial or axillary hair. So non-classic CAH we need to think of. And lean PCOS, so-called lean PCOS phenotype could actually be non-classic CAH. So what forms of CAH will cause ambiguous genitalia in males? So I think we discussed that. So these are the common forms. The proximal enzymes in the steroid synthesis, basically, where all the lines are affected. Androgen synthesis, cortisol, and aldosterone, they will usually present with ambiguous genitalia in male, where androgen synthesis is also affected. The androgen limb is also affected. So these are those enzyme deficiencies. Just to mention here that Smith-Lamley-Opitz syndrome, although not a CAH, but this is the first step in the steroid synthesis, and 7-dehydrocholesterol reductase is the enzyme deficiency, which can lead on to this syndromic condition along with adrenal insufficiency. So what forms of CAH will cause ambiguous genitalia in females? So that we know 21 hydroxylase, where androgen excess is there. The block is at the step after the 17-hydroxy progesterone step, and the whole of the steroid synthesis is diverted toward the androgen excess. So what forms of CAH will cause ambiguous genitalia in both sexes? So that's another, so these are the two possibilities, 3-beta HSD.
Rakesh sir,
Yeah.
Madam OPD starts at 6:30. So can we complete within 5 minutes? 5 minutes. Yeah. Thank you.
Yeah. All right. Okay. So in fact, I can stop, and most of the things we have discussed. So just to show the residents that this is the figure I think you should always remember, or you can paste this figure around nearby so that you know what enzymes are working at what step and what are the deficiencies likely to result into. So I'm not going into details of this. I'll just quickly skip this. Yeah, I think there is a lot to discuss otherwise, but I think it is all right. So it may be all theoretical. What is atypical genitalia and ambiguous genitalia? Atypical genitalia is basically a broader term, which includes even distal hypospadias or maybe unilateral undescended testes. So all atypical genitalia will not be DSD or ambiguous genitalia. So for CAH in examination, we have to particularly look for shock, dehydration, hypertension in older children. Hyperpigmentation and genitalia examination is obviously important. So when we examine the genitalia, these are the important parameters we have to see: asymmetry, labioscrotal folds, phallus, penile length, what is normal we need to know. There are formulas to calculate for age. Penile diameter is also important. The girth of the penis is also important. So isolated micropenis, what are the conditions we should know? Clitoral enlargement, what are the cutoffs? So external genitalia, again, urogenital openings are important. Gonads, when we palpate gonads, it's always important to have milking action. So when we examine gonads, sometimes because of retractile testes, they can go up and you may not be able to palpate them. It's always important to start upside down rather than starting to palpate from down and then going up. So milking is important so that you don't miss a retractile testis. I think for the sake of, so there is one score which I was talking of. So external genitalia score. So this is a gender neutral score where the scoring is based on whether the labioscrotal fusion is there, what is the degree of fusion, unfused, posterior fusion or fused. Then genital tubercle is the neutral term for the phallus, which we normally call phallus. It should ideally be told as genital tubercle and we should measure its length. We are not saying here it as clitoris or phallus. We are calling it as genital tubercle. So these are general neutral terms which we should be using when we are not sure about the sex and when we don't want to actually commit to either sex. So these are the neutral terms which we ideally should be using in our examination. So this score may be better compared to other two, but so the others, the Prader score and EMS has been used for long, but this may be newer addition to this objective scoring for ambiguity. So urethral meatus, where is the opening? So accordingly, we can give score. So it's in short called EGS or external genitalia score, and these are the parameters. So maximum score here is 12 and minimum can be 0 and it could be abnormal would be anywhere from 0 to less than 10.5. Okay.
Sir, can we conclude within a minute? Yeah.
Yeah. So I think this is summary for the examination. We can stop it here. Thank you, Dr. Amarnath. Yeah.
Thank you very much, sir. Just few important points, practical points for the pediatricians and the postgraduates are: please refer all CAH case to pediatric endocrinologist and monitor 17 OHP. Most of the people are monitoring only serum electrolytes. That's not correct. So monitor bone age, growth and puberty, very very important. Titration of the dosage, all those things will be dealing in our ASCII. So please note, please refer to pediatric endocrinologist, especially all CAH case and DSD case. Thank you very much, sir. It was an excellent discussion. Thank you, Madhuri, for your excellent presentation. Now I request Dr. Sudharao Madam to be the examiner. She is professor from BJ Wadia Hospital, and Dr. Panda Shrestha from Indira Gandhi Institute. You be specific and in short present the case. Next case of DSD. Over to you, Shrestha. Welcome, madam.
Thank you. Thank you very much for having me here. I'm sorry, Dr. Rakesh. We had to rush this because, I'm sorry. Please go ahead with your presentation.
Go for slideshow. Slide.
Yes, is there any
Slideshow. You are not able to do?
You have to click on view.
View.
1 minute.
You can stop share and download and then reshare it. Open it and then reshare.
Actually, the talk panel is open on the talk, so that's why it is not like I'm not able to view the option of slideshow.
Which is
No.
why, ma'am, you have to stop share first.
But that
Stop
option is
sharing
only
now.
not. Is
No, you
not.
come out of the you come out of the sharing and then reshare again. Yeah, correct.
Uh,
Ma'am, can you switch on your video?
yeah. Video is on. Like.
Now open your PPT in the background.
It's open, but I am
Share
not.
screen.
After I share screen, it's not like slide share. Wherever the slideshow option is there, that was only hidden. So I had to download. Okay. Sorry for the delay. Good evening, everyone. I'm Dr. Shrishta, second year postgraduate from Indira Gandhi Institute of Child Health, Bangalore. My topic, I'll be presenting my case, name
We
XYZ.
can't see your shares.
Yeah, Nishad, I have shared the presentation. Nishad, you can
Yes,
download and present it.
Okay, I'll share it.
Yeah, I have sent you on WhatsApp.
Now also it is not visible.
No, not it.
You want to
Okay.
do it again?
Yes, sir. I'll just do it again.
Yeah, I have sent your presentation to Nishad. He will help you out.
I don't think he has the final one of mine. The
Good.
exactly where. Oh, 1 minute.
When you press share screen,
Yeah.
you have to select the PPT, not anything else, just the PPT.
Madam, can we have your presentation and second will be her presentation?
I
Can we
think
do
that-
like that?
Yeah,
If we are getting delayed, Madam will present the approach. Yeah, thank you.
Is it okay? Is it okay with Eshta?
Yes.
Are you okay with it?
Yes, ma'am. I'm trying
Are you
to
okay
find out.
doing like that? Are you okay to do your presentation afterwards? That's fine then. Yes. Maybe we could do the screen share. You had sent me a very beautiful presentation, and I think all of us look forward to seeing it shortly. So, are you able to see my PPT?
Yes, ma'am.
Not yet, madam. Not yet.
I'm still able to share my screen. Is there a problem in that?
Yes, sir. You need to
Looks
stop.
like look. No,
You need to stop, sir.
I have stopped already.
Okay.
Okay. Can you see my screen now?
Yes, madam.
You
Yes.
can see my screen. Okay, thank you very much, Bangalore and Dr. Amarnath and everyone for having me here. I would take a very brief, what is it called?
Madam, slideshow, madam. We want slideshow.
It is slideshow.
Ma'am, click on your screen once, please.
Yeah.
Click 2-3 times.
All my slides are coming ahead. I go back.
We can't see the slides.
Can you see this? Can you can you see my slide?
Not
yes,
yet.
Loading.
Yes, madam. Now, well, go ahead. Madam is an excellent teacher and examiner too. She's a professor. Thank you to madam. Thank you.
Can you see the Vadia slide? Yes.
Yes, madam. Excellent. Go ahead.
Very brief. We can write an approach for childhood DSD. Take in a brief way. So when we speak DSD, I understand most of us in the audience are residents and postgraduate students or endocrinologists. Just to give a brief outlook here, the problem of DSD is one of problem of CG, which is related to the genetic sex, gonadal sex, genetic in this whole scenario. So now, can I get a clue that you're able to hear me?
Madam, some internet issues are there. We are not able to hear in between, and your screen also not visible.
Ma'am, maybe try to switch off your video. That might help. Ma'am, try to switch off your video.
I'm trying. Can you switch off my video?
I'll do it now.
Slides not visible, madam. Yes, Mayank, any issues?
I think it's from ma'am's side.
Okay, some madam has got some net issues or something.
Network issues.
Yeah, network issues. Shrestha, can you try till madam comes? Otherwise,
Yes, sir.
you are able to?
I can share the screen, but once that PPT is coming on the screen, that slide share option is only not visible.
Just see, just see. Nishad, I have sent the PPT to you. You can try.
Ma'am, I'll share it from my side if you don't
Okay.
mind.
Yeah,
Okay,
yeah,
sir.
go ahead.
You can stop sharing.
Okay, sir.
Sudha madam, are you ready, madam? I request Rakesh sir also to be present, and we'll troubleshoot till madam comes. Myself and sir will be there. Yes, you can start presentation.
Okay, sir. Good evening, everyone. I'm Dr. Shrestha from Indira Gandhi Institute of Child Health. So, beginning with the case, next slide. Name XYZ, 7 month, reared as female from Bangalore, informant being mother, reliable, was examined on March 16. Next slide. The presenting complaints in this child was increase in phallic length noticed since last 1 month. Next. Parents informed at the time of birth of the child that baby is female and was being reared as female, but by 6 months of age, mother noticed progressive increase in phallic length. No history of excessive pigmentation of the genital region, no history of excessive urination or failure to gain weight or weight loss, no history of vomiting, loose stools, severe illness requiring hospital admission, and child was passing urine from perineum. Next. No history of no past history of hospitalization or any drug administration. Next. Family history. Child is second born to third degree consanguineously married couple with first being one abortion, spontaneous abortion at 2 months. First sibling, 3-year-old male child, normal. No history of ambiguous genitalia in the first child, and this no family history of any ambiguous genitalia or infertility or any adoption history in family or delayed puberty, female virilization, hirsutism, acne, any male having female-like voice or amenorrhea or any corrective urogenital surgery being done in family. No history of early infant death in family. Next. Antenatal history wise, age of conception was 22 years. Mother was a registered case. Pregnancy confirmed by UPT. Mother had taken iron and folic acid tablets. No significant history being history of vaginal candidiasis at 4 months of gestation, for which she had taken antifungal medication, and there was no history of virilization in mother or no history of steroid exposure or OCPL consumption in mother during pregnancy. Next. Natal and postnatal history. Child is single term, born by LSES, elective LSES, 2.5 kg birth weight, cried immediately after birth, no NICU admission, meconium passed within 24 hours, and breastfeeding initiated within 1 hour of life. Next. Next slide. Development wise, it's normal. Baby has attained age appropriate developmental milestones. Next slide. Next. Next slide. Immunization. Baby is immunized as per age and received last dose at 14 weeks of 14 weeks of life. Next slide. Nutrition wise, baby was exclusively breastfed till 6 months of age, and weaning started at like 10 to 12 days back. Weaning was started with 6 feeds per day, 2 to 3 spoons per feed. Ragi porridge was given. Calorie wise, there was a deficit of 240 kilocalorie. Next slide. Socioeconomic status, they belong to upper middle class family as per modified Kuppuswamy classification. Next slide. So summary from history part. 7-month-old reared as a female child, second born to third degree consanguinity, presented with parents noticing increased length of the phallus since last 1 month without any hyperpigmentation and without any history suggestive of salt wasting crisis. Next slide. So
Yeah, go back. We'll ask the audience to tell you a diagnosis. So previously we saw the undervisualized male here increasing in length of the phallus. So what could be the possibilities? So yes, you can tell.
मैं यहाँ पर डॉक्टर लाउंज में हूँ, मुझे 1/2 घंटा लगेगा.
Yes, go ahead, Shrestha. Yeah.
The differentials in this will be like it is an undervirilized male or virilized female. Undervirilized male, the causes can be partial androgen insensitivity syndrome or 17 beta hydroxysteroid dehydrogenase deficiency, 17 beta HSD deficiency, or or it can be a virilized female. Like if case mother is exposed to androgen in antenatally, it can be virilized male, or simple form virilizing form of CH, but that will present late, not in infancy. Next.
What simple examination can differentiate both?
So palpable gonads.
Very good. That is the first step in approach to DSD. Very good. Go ahead.
So general physical examination wise, child was alert, active, hemodynamically stable, no hypertension was noticed, and sugars also
Which
maintained.
type of CAH will have hypertension?
Sir, 17 alpha hydroxylase will have hypertension, like
More common than that?
11 beta also.
Yes. Good.
Then.
And what is the importance of blood pressure in most common 21 hydroxylase deficiency?
Blood pressure?
What will happen in 21 hydroxylase deficiency?
Sir, in 21 hydroxylase deficiency,
blood pressure.
Hypotension may be noted.
Hypotension, so
Yeah.
adrenal insufficiency and hypertension.
Very good. We want you to just summarize the case. Madam has come once again. Sorry, madam, we have come back. Just summarize the case, no? Summary.
Okay, sir.
Madam want to ask some questions. Over to you, madam.
Yeah. In your brief summary, you spoke of, I hope you spoke of progressive increase in cardiac.
Can you go back 2 slides, Nishar?
Okay.
You spoke of progressive.
Go back. Yeah.
I remember the history which you sent me. So what are the salient features in the summary which you would want to be focusing on? Can you tell some points in the summary which is important?
Ma'am, consanguinity is one thing.
Yes, which means,
and
what does that mean? Consanguinity points towards?
In autosomal recessive conditions and X-linked can in family history of ambiguous genitalia can present.
So which are the conditions of atypical genitalia? We will use the term atypical genitalia rather than ambiguous, because ambiguous itself has its connotations of being odd, so we will rephrase our term as atypical genitalia. So what are the conditions of atypical genitalia which are inherited as autosomal recessive? Do you know? Meaning, was it discussed, or can you name a few conditions which are inherited recessive?
Congenital adrenal hyperplasia can.
Yes. Besides that, very good.
Partial androgen insensitivity, also like receptor mutations. Some receptor mutations are X-linked.
Yeah, but it's not recessive, right? Do you know of any other atypical genitalia which is inherited recessive? Is enzyme defects, like 5-alpha reductase. So these are the two essential conditions presenting with atypical genitalia which are inherited autosomal recessive. Like you said, androgen insensitivity, that is X-linked. Okay. So third degree consanguinity makes you think in terms of possible recessively inherited disorder could be there in when we are going to see this child and examine this child. Anything else which is interesting in this history, or which forms an important point in this history?
Being reared as a female and seeing a growth of the phallic length. So that is one thing, and there is no history of like salt wasting crisis or any hyperpigmentation.
So so from the history, the questions, I think I will not do my talk in detail, but we will do this presentation here. From the history, we should be able to make out whether this is an atypical genitalia, 1. 2, if there is an atypical genitalia, is it associated with any growth faltering? The growth could be in the form of poor weight gain, or it could be in the form of excessive height gain. So here you're having a progressive virilization that is happening in the form of increased genital tubercle, which is happening in the last 1 month, to be very particular. No? So maybe they have noticed this increase in genital tubercle in the last 1 month. So what does this tell you from the history? Increased genital tubercle, increasing length of the genital tubercle last 1 month tells you in terms of what? What does it tell you?
There's something progressive,
Yes. Progressive with a influence of which type of hormone?
Testosterone, ma'am.
Androgens,
Androgen hormone.
So maybe there is some effect of androgen happening in this child who's reared as a female.
Yes, ma'am.
Born of third degree consanguineous marriage. Having said that, it should also be looked at in the perspective, possibly they noticed it now when the child became older, or did it indeed increase in size in the last 1 month? These are the two specific questions which we should be answering or eliciting in the history. Okay. So we have a child who's born of a third degree consanguineous marriage as a progressive enlargement of the genital tubercle, but there is no failure to thrive, there is no admissions, no crisis, right? So like Dr. Amarnath said, you need to know whether on your examination, focused examination, if we do on this child, what are the points of focused examination you would want to do?
First will be, ma'am, palpation of the external genitalia examination, ma'am.
Okay, so we always start from general examination and then go to local examination. So in general examination, what would be the focus points you would want to see?
Any skin hyperpigmentation.
Okay, where do you typically see for hyperpigmentation, and why do you want to see for?
In congenital adrenal hyperplasia, there will be hyperpigmentation in the apart from the external genitalia around the nipple areola region, the axillary region also will be having hyperpigmentation.
So why do you get hyperpigmentation in them?
Because of their sensitivity to the hormones, ma'am.
So pigmentation is related to ACTH.
ACTH, ma'am.
How does ACTH cause pigmentation? What is common between ACTH and pigment the skin is the MSH, right? So increase CRF, increasing MSH. So that's why how you get your pigmentation, but it is essentially on the creases. Yeah, on the palmar crease, in your axilla, maybe even gum pigmentation, you would want to see for any presence of excess of ACTH. Okay. So what other focused examination you would want to do on general examination? One is you said you want to see for pigmentation because there is a progressive increase in phallic length, which you feel is because of androgen driven. And that means you're also thinking of possible.
Other mineralocorticoid and cortisol.
Next would be on examination, what focused would you want to do? You want to see pigmentation. Anything else? I think it was discussed briefly. What would you want?
Any
Okay,
dysmorphism,
dysmorphism.
any
Okay.
skeletal abnormalities.
Very good. Okay. So we should not forget measuring blood pressure. So besides your vitals, the blood pressure, the pigmentation, any obvious dysmorphic features, which syndromes of dysmorphism will be there, which present with atypical genitalia? Can you speak of any syndromes which can have atypical genitalia?
Like Prader-Willi syndrome can have microphagus or not Turner's, even and Robinow syndrome and Antley-Bixler syndrome and
Yes. Yeah, so you have various dysmorphic syndromes which can present, like even Smith-Lemeli-Opitz syndrome. Then you have syndromes, even Down syndrome, even Turner, why not? Even they may have an atypical genitalia. So you would want to see for dysmorphic syndrome, Smith-Lemeli-Opitz. Antley-Bixler comes more with skeletal dysplasias. SOX9 mutations again may have skeletal dysplasias as presentation. So you would want to see for asymmetry, you would want to measure the length, you would want to measure the head growth, and you would want to see for telltale features of midline defects, cleft lip, cleft palate, which can be even coloboma iris. You would want to see for general examination features which could point towards a syndromic cause, and then features which would point towards an underlying criticality of the face, right? Okay. Then what else you want to do? One thing, take home messages, don't forget measuring blood pressure in any child who comes to you with atypical genitalia. Okay. Then on any other, after general examination, what would you want to check?
From head-to-toe examination, then we'll come to after dysmorphism and on external genitalia.
Yeah. So can you put up your slide on how the external genitalia looks? Can you go ahead on your slide?
Can I share?
Just 1 second, madam. Sudha madam, just you have completed history only. Examination is not yet over. Okay. Just one point I wanted to mention here to Dr. Panda. Myself and Dr. Shaila madam also told the same thing. You have not commented on history, whether parents have noticed the testis or not, gonads. So we will see in the examination. It may not be important for them, but for pediatrician and pediatric endocrinologist, examination of the both the gonads is important, whether you are able to palpate or not. Go ahead.
Can I share my own screen now? I want to share my last, like once. Now I figured out. I think this time it will be possible.
Yeah, we don't have a time. We'll go ahead. Yeah.
Because this was not my final presentation. Actually, that's why.
It's okay. Shrestha. We will discuss.
Nishad, can you try once? It's okay. Yeah, you present.
Time is not there. The genitals. Can you describe the genitals?
Okay. Next slide.
Next slide.
Yeah.
Next.
So what does this tell you, the anthropometry? Do you want to comment because you
go back, Nishad? Yeah.
What does this tell you?
Ma'am, the child was having failure to thrive, the weight being less than 3rd centile on the growth chart. And height was at 3rd centile, but weight for height was in between 3rd to 50th. Head circumference being normal.
So what does this tell you? In a child with atypical genitalia, the next question, like I said, you are supposed to ask is whether the child is thriving well or not. So according to you, the child is thriving well?
No, ma'am.
Is
As
the
per
child thriving well?
examination, child was not like as per anthropometry. No, ma'am.
Yeah, the weight, but the weight for height is
Yes,
okay, you
yes, ma'am.
mentioned.
Yes,
Uh,
ma'am.
Yeah, only the weight is less and the length is length is on the third centile. So maybe it's more of a weight affection rather than failing to thrive both in terms of weight and height. Okay. Yeah. So that is important to see when you have an atypical genitalia, whether the child is growing well or not. Why is it important? What does failing to thrive indicate to you?
Ma'am, when congenital adrenal hyperplasia, mostly they will have poor weight gain or failure to thrive.
Yeah, so whenever there is
And
a salt wasting form of
salt.
CH, so they lose salt, they are low on, say, recurrent hypoglycemia goes unnoticed. So there are metabolic issues, metabolic scenarios happening because of in the presence of an atypical genitalia, commonly is CH, and you do have salt waste happening in some forms of CH which are not with cortisol or mineralocorticoid deficiency. So failing to thrive in an infant with an atypical genitalia speaks in terms of underlying salt wasting scenario or a recurrent hypoglycemia secondary to hypocortisol state. At the same time, in an older child, for example, 3-year-old, 4-year-old comes to you with a fast growth in height, so he's tall for his age, and you have features of progressive phallic growth. There again, we can make out that there is some degree of androgen excess, which is driving this child with atypical genitalia to grow, right? Okay. Yeah. So this child is not growing in terms of weight, but is okay in terms of weight for height. Next, yeah, proceed further, please. Next slide, please. Next. Yeah, now describe this genitalia. Yeah.
Yes, ma'am. The external genitalia in that, ma'am, the right side gonads was palpable in the scrotal sac, and the left side was palpable near the external inguinal ring.
Okay.
So there was evidence of palpable gonads. The scrotum was bifid, and the stretched penile length was 2 centimeter. With there are dip at the tip of the phallus, and the urethral opening present at the junction of the base of the phallus and the scrotum. There was penoscrotal hypospadia.
Nishad, next slide. Yeah.
Yeah, so you are saying you could palpate your gonad on one side in the scrotum, and the other gonad was palpable in the inguinal ring, and you had a perineal kind of hypospadias, right? Perineal single opening. So when you describe genitalia, if we go to the previous slide, you should speak of symmetry or asymmetry. So now, can we go to the previous slide? Yeah, so this looks also a bit asymmetric. If you see, the left side looks a bit hanging down. So the genitalia at the first glance looks a bit asymmetric. Then go ahead, please. Then you could palpate you could palpate the gonad on one side. You could palpate the gonad maybe at the inguinal ring on the other side. So the gonads were palpable bilaterally. There was good scrotal rugosity. The scrotum was well developed and rugose, and the phallic structure, you said measure 2 centimeter in length. It is okay, also good practice to measure in terms of the width, and also comment on the glans. Here the glans is well developed. If you see the previous slide, the glans looks well developed, and there is a single opening. See, this is the glans which is well developed. Sometimes poorly developed glans gives you a pointer towards decreased action of dihydrotestosterone. So when the testosterone is getting converted to dihydrotestosterone, usually the glans is well formed. A poorly formed glans tells you maybe there would be a conversion defect. And then you have a penoscrotal or a penoscrotal kind of a hypospadias. You should also mention where is the anal opening. So anal opening is also well visualized. So to summarize your genital examination, there is mild asymmetry. You have well-formed rugose labioscrotal folds. Your gonad is palpable on the left side in the scrotal sac. The right gonad is palpable in the inguinal region, but easily felt. Normal in consistency, good in feel, and normal in consistency. The phallic length is about 2 centimeters by whatever centimeters. The glans is well formed, and you do have a single opening, which is at the pinoscrotal region. Anus is placed at the normal position. This would be the full description of the genitalia when you describe atypical genitalia. Okay, go ahead. So rest, I think we are not so much worried about the systemic examination, etc. I know you have one slide for each system. So which system will you be worried about when you have an atypical genitalia?
Ma'am, GI system, like hernial sites, we should look for any inguinal hernia.
Okay.
Like inguinal mass, to be specific. Then
Okay.
other system wise,
Skeletal system you already said. Good.
the head to toe examination. And next is if like in case of sick baby, salt wasting crisis, and that all systems will be more like for look for dehydration, any acidotic breathing or other.
Okay. So shock and cardiovascular system.
Cardiovascular.
So you could make a habit of palpating the kidneys. If there is some obstructive renal issue in an opening which is abnormal, you may have reflux nephropathy and hydronephrosis, hydroureter. Sometimes, rarely, you may have palpable kidneys. So make a habit of also looking at whether the kidneys are ballotable, bimanually palpable. And yeah, so that is one thing which you may be looking at. So now with this, yeah, that's right. Someone said genitourinary system examination.
Go
right.
next slide.
So
next slide.
Go ahead. Yeah, go ahead. Next. Go ahead, please. Next also.
Next. Yeah.
Now, how do we approach this child? What is your provisional diagnosis?
Ma'am, provisional diagnosis will be with palpable gonads, 46XY DSD.
Yes.
More likely partial androgen insensitivity syndrome or 5-alpha reductase deficiency or 17-beta HSD deficiency.
So in your examination, you had in your history and further, you did have slight failure to thrive in terms of weight. Yes, of course, weaning period, 7 months of age, those nutrition aspects are there. But indeed, if you say bilateral palpable gonad, and I say that failure to thrive is significant. So which type of, you said adrenal causes come to you with failure to thrive. So which adrenal cause can have bilateral gonads palpable and still have adrenal insufficiency? So what is the spectrum? What is the spectrum of disorders where you may have gonads palpable and still be a CAH? Okay, let me not confuse you. From the phenotype that you are seeing, what could be the phenotypic impression here? What is the phenotypic impression here?
Phenotypic impression will be male, ma'am.
No, so it is an undervirilized male.
Undervirilized
so you're suspecting a 46XY DSD, which would be like a undervirilized male. So common causes of that are, what are the causes, do you know, of undervirilization of XY
Undervirilized, ma'am, due to decreased testosterone production, as in the enzyme deficiencies, or because of testosterone inaction, like partial and insensitivity or complete insensitivity. In complete insensitivity, it will be more of a female genitalia. Complete female genitalia.
So something that's I always say in endocrine, you either have the gland or it doesn't synthesize or it doesn't act. So here, testosterone synthesis defect, testosterone biosynthesis defect. Even before that, you have something like Leydig cell hypoplasia, which will not be so well virilized. They would be very poorly virilized XY-DSD. So Leydig cell hypoplasia, testosterone biosynthesis defect, conversion of T to DHT is 5-alpha reductase, and then you have end organ resistance like partial androgen insensitivity syndrome. So this would be your spectrum of differentials in this case. How do you want to investigate? Have you investigated this child?
Yes, ma'am. Investigation, blood investigation wise, ma'am, specific to this, there was no hyponatremia,
Michelle, next
hyperkalemia.
slide. Yeah, next slide.
There was the serum electrolytes were normal, and RFT was also normal. Sugars were also maintained. Next slide. We had done karyotyping also. Karyotyping was positive. Karyotyping was 46XY. And beta HCG stimulation test was done. At 0 minute, it was 64 nanogram per deciliter. At 72 hours, it was 123. The testosterone levels was 123 nanogram per deciliter. So there was good response to HCG stimulation. More than 100, usually we tell it is more good response. Androstenedione was 0.14 nanogram per or 14 nanogram per deciliter, and DHT was 16 nanogram per deciliter. The ratios of testosterone to androstenedione and testosterone to DHT, which we do to differentiate between 5-alpha reductase deficiency and 17 beta HCG, was normal. Like testosterone by androstenedione ratio less than 0.5 is normal, is less than 0.5 is significant for 17 beta HSD, and T by DHT more than 10 will be for 5-alpha reductase.
Okay, good. That's a very good workup, which has taken
Imaging
place
was
here. So
done.
now what is your final diagnosis?
Imaging was done. Imaging showed bilateral, there was evidence of 2 oval-shaped hypoechoic structures along the inguinal canal, bilateral compatible with testicles, and uterine body and cervix was not visualized.
Why you want to look for uterine body and
For Mullerian structures, Mullerian presence or absence of Mullerian structure.
what is your diagnosis in your mind? If it is presenting like this.
Sir, if it is presenting with ambiguous genitalia at birth with palpable gonads, like features of undervirilized male with karyotype showing 46XY. So more likely partial androgen insensitivity syndrome.
No, presence of Mullerian structures we are telling.
Okay. Presence of Mullerian structure. So it can be persistent Mullerian duct syndrome.
Yes, very good. And you should do extensive karyotyping. Look for ovaries and the possibility of both 46XY and mixed DSD XX. Okay. Yeah, go ahead.
So in this case, it was 46XY DSD, suspected partial androgen insensitivity syndrome, and further test with supplementing with testosterone and looking for the increase in phallic length was awaited, and genetic study was awaited.
What other investigation you want to do? LHFSS testosterone, have you done?
No, sir, LHFSH was not done because a child was already in 6, 7 months. That is the time when the hormones will be like peaking and then coming down. So it was not done.
Yes.
Yeah. So what are the challenges in further talking to this patient and their parents? What are the challenges you foresee? So there are lots of challenges here, right?
Social challenges will be the first one.
Yes.
Because at birth they were told baby was female, and for the past 6 months they were rearing as a female.
Mm. And what else? So many, no? So one is gender of rearing itself needs to be, sex of rearing, sorry, itself needs to be discussed with them again. And there has to be a kind of team related approach to how do we counsel this family. Then you have issues in terms of, once the gender of rearing, sex of rearing is, say, taken care of, then child needs to be monitored, followed up right up to the pubertal and post-pubertal age group. So the child needs to be with maybe a constant physician, maybe you as his pediatrician, the child should be with you till the child goes through the puberty and further, because the challenges are not only of today. This child needs to be properly followed up to give the best. And one thing important is we should not have a life-threatening situation as far as any typical genitalia is concerned. So psychological support, social support, then of course surgical, any support needed at an appropriate point of time should be discussed. So it's not one time that you diagnosed and you're leaving. No, the child should be following up right through, and we must guide them through the puberty and further care. It's a big challenge to take care of an androgen insensitivity syndrome child as compared to, say, CAH, or because there the diagnosis, you have guidelines of care. Here there are lots of issues which needs to be considered. Okay, well presented, nice. I'm really, you said 0 minutes and 72 hours. You said 0 minutes and then 72 hours.
Yes, madam.
You give HCG for how many times do you give HCG? What is the protocol that you follow?
2000 international unit IM, prior to administration of the dose is measured, and after 72 hours.
So every day you give, or every alternate day you give? How do you give? Every day? You give every day.
Oh.
Okay. So there are
Only
various
once, madam.
schemes.
Only once we do in IGACH, not
Only
every day.
once you give.
Yeah.
Yes, ma'am.
And then you check it after 72 hours. Okay.
Yes, ma'am.
Yes, ma'am.
Okay.
Shrestha, one question for you. The same child coming increase in phallic length at 12 years of age, that is Penny's at 12 syndrome. What is your diagnosis?
It can be, sir, a virilized female, sir, like clitoromegaly can be there at puberty. It can be because of 3 beta HSD. Like at puberty, at that time, testosterone getting converted to DHT and causing virilization in a
Very
female
good.
child.
5 alpha reductase deficiency. It's called Guillain-Barré. Yeah.
Yes, ma'am.
Over to you, madam. Sudha, madam.
Here, what do we do?
Rakesh sir, you have any comments?
Not really. It's, yeah. Ultimately, looks like both cases came out to be XY DSD.
Yeah.
So there was a lot of overlap actually. Yeah,
Yeah.
but the first case was more complicated in the sense there had a lot of other anomalies. So it
Yeah.
was not a straightforward case.
Yeah.
And in the first case, many things are still actually not sorted.
Yes.
We don't have a etiological or primary
Yes.
diagnosis.
So,
And CAH, whatever the investigations are pointing to 21 hydroxylase deficiency.
Yes.
But the clinically patient is not fitting into that.
Yes.
So that is the problem in that case. So these hormone assays we were discussing with Dr. Madhuri as well. So these
Yeah.
hormonal assays in this child, 17 UHP done at day 4 of life. So sometimes there could be false positive issues there,
Yeah.
and the maternal hormones playing a role, and then type of
Yes.
assay. So we have to actually, these are dynamic hormones, and we have to repeatedly do actually and see the overall physiological status of the patient, and then in light of that we have to interpret these hormonal assay results.
Yes. Yes. Thank
So
you.
that is important message here. Yeah.
Madam, we were able to see your slides, not in slide
Sorry,
starter view, but all slides.
you're able to see my slides?
No,
Are you
madam.
able?
If you have
No.
trouble, you can share in the
So
group or mail to me or Nishad.
yeah, I think I'll do that. But meanwhile, let me just put the whole thing in perspective for, though it's a talk kind of a thing.
Yes.
Can
Yes.
I be made visible, please? So for all the people who are here,
Madam, can you share
can you
your
see?
PPT or something?
Yeah, I'll do that. Can you see my slides? No. No?
Yeah. Yeah. Now we are able to see. Yes.
Can you see now?
Yeah, you can go ahead. Slide sorter is not there, but better. You can go ahead.
Okay. You can see this, is it?
Yeah, you can go slide view. Yeah, now we are able.
Okay. So now when we speak of, I think I'll skip most of it. We have done a lot of theoretical discussion saying, so atypical genitalia is not an uncommon disorder, but for all of us to understand atypical genitalia, some amount of basic embryology has to be seen. So like it's shown in this picture, it starts from the urogenital ridge. In the presence of some transcription factors, this bipotential gonad gets differentiated into testis and ovary. I think we should understand this basic thing because most of our differentials can be sorted out based on what we are seeing here. The testis gets further differentiated into Leydig cell and Sertoli cell. So the bipotential gonad in the presence of SRY, which is present in the Y chromosome, which is determined by the chromosome X, determined into testis. The testis then differentiates into Leydig cell and Sertoli cell, and that is called gonadal sex. The chromosomal sex brings about the gonadal sex, and the Leydig cell and Sertoli cell have their own functions, like we heard testosterone synthesis, conversion to dihydro, and then the differentiation of the internal and external genitalia. The Sertoli cells causes Mullerian inhibiting substance formation, which in turn causes on further
Sudha, your
makes you
slides have
understand
disappeared.
about the. Is it come back now? Has it
Sudha,
come
your
back
slides have
now?
disappeared. Yeah. Oh, gone.
Now?
No. Yeah, you can do slideshow now.
Yeah.
Yes, madam, you can go ahead. No issues.
Or maybe I'll send the slides to you, you share it everyone. I'll just put forward my points,
Yes,
which
yes.
is essentially in terms of gonadal differentiation, gonadal determination, differentiation, and then differentiation of the external genitalia. When we speak problems of DSD. It's essentially due to these 4 or 5 reasons. When the potential gonad does not get determined needs to differentiate into Sertoli cell and Leydig cell. I think I will send you the slides.
Ma'am, you can share in chat box also. There is an option of like page, and you can direct drop in your PPT file over there.
अभी आ रही हूँ मैं यहीं पर हूँ आ रही हूँ या
So till Madam joins, we wanted to share few interesting things about DSD. So we used to have DSD clinics uh, for which uh, a psychologist, geneticist, and a social worker and the pediatric endocrinologist used to come. So it's a very complicated topic. So we need to have a combined approach and needs proper counseling, taking consent, and you need to do the even psychological assessment too. So we asked, how will you do psychological assessment from the psychologist, including pediatric surgeon or urologist. So, so females have the attraction towards the toys, soft toys, and males have aggressive behavior. So these are few things to note. So involving the psychologist is also a very important thing, and periodic counseling is important. We had other interesting cases like male child with CAH. We counseled genetic counseling, but Muslim patient did not listen again. Within 2-3 years, again came with one more CAH patient. So not taking care of proper follow up and coming to the doctor. So involving the geneticist and the counseling is very important in congenital adrenal hyperplasia. We had one more interesting case in Hyderabad. So 6 years child coming to me with mustaches and beard. His bone age was almost 14 years. So why this happened? Because pediatrician was doing only serum electrolytes monitoring, no puberty monitoring or the bone age assessment. So it is very important to look for the growth and do 17 OHP monitoring, plasma activity monitoring, and blood pressure monitoring. All these are important. So, we are waiting for Dr. Sudha Rao. What is the first step in the approach to DSD is palpating the gonads. That is the first step. So we'll come to know whether it's a 46XY DSD or 46XX DSD. Later, look for the Mullerian structures and do LHFSS testosterone. Increased LHFSS testosterone in 46XY DSD indicates CAIS, that is complete androgen insensitivity syndrome. So most common 46XY DSD is CAIS, and most common 46XX DSD is the congenital adrenal hyperplasia. Most common is 21 hydroxylase deficiency. So most commonly missed CAH is simple virilizing type of CAH. They don't have any crisis, but they will be presenting to you with the premature pubarchy or adrenarchy and increased height. So we should monitor the growth in these children and do synactin test, that is ACTH stimulation test, when it is inconspicuous. 17 OHP values are in between. So Nishad, can we know madam is coming? Sudha madam? Or we go ahead with the next Trotsky presentation?
I think she has a network issue, so she didn't connected. And we have a ready presentation of Vani ma'am. So if you want to continue.
Yes, you can try madam by sharing.
Good evening, everyone.
Yeah, Dr. Vani, she is Associate Professor from Indira Gandhi Institute of Child Health, at present the in charge taking care of the Pediatric Endocrinology Fellowship at IGICH. It's my parent institute. We are grateful to Dr. Raghupati sir, is not able to join today. Over to you, madam. Thank you.
Good evening, everyone. At the outset, I thank Dr. Amarnath for providing me this opportunity. I kindly request you to bear with my voice as I'm recovering from laryngitis. Are my slides visible?
Yes, madam. Go ahead.
Yeah. So let's come to the first question.
Just 1 second. The instructions to the candidate, please answer in the chat box. It's an interactive session. So 30 seconds time we are giving for all the candidates, especially for DNB. So please be interactive. We'll be waiting for your answers. Thank you.
16-year-old girl presented with primary amenorrhea with normal breast development and normal female genitalia. On palpation, gonads were found in the inguinal region and ultrasound showed no evidence of Mullerian structures. Karyotype 46XY. What is the most likely diagnosis? Please type your answer in chat box. So as you can see, there is a discordance between the genetic sex, which is XY, and the phenotype. So definitely this is a DSD case. So what could be the most likely diagnosis?
Dr. Divya and Himmat wrote androgen insensitivity syndrome.
Very good. So again, it has types, no? So what is it? Whether it's partial or complete?
So
because
Dr.
it's a normal.
Dr. Konda wrote CAIS, complete androgen insensitivity.
Yeah, very good. So what hormonal test would you do? And what results do you expect?
Yes, answer.
Yeah. So in this situation, it's because of the resistance at the receptor side. So the hormone, testosterone, and the FSH, everything will be high. The next question, should the gonads be removed? If so, why? Yes.
So higher chance of malignancy by Dr. Himmat.
Yes. So she's an adolescent, already normal breast development has occurred. Okay. So taking consent from adolescent is fine. And in case of complete androgen insensitivity, the risk of malignancy is less compared to partial androgen insensitivity and other disorders like gonadal dysgenesis. And in androgen insensitivity, we allow the gonads because the testosterone gets converted to estrogen which is required for the normal breast development, the contour, which is not possible with medical supportive with estrogen therapy. So let's see some conditions wherein there is high risk of malignancy. In case of gonadal dysgenesis, the presence of Y chromosome is always danger. And in case of intra-abdominal testis, partial androgen insensitivity, wherein the gonads are not in the scrotum, Frazier syndrome, Denish-Drash syndrome, the risk of malignancy is very high. So in case of Turner's with Y chromosome, again, there is an intermediate risk. And in case of gonads present in the scrotum, in case of partial androgen insensitivity, the risk is intermediate. Whereas the risk is low compared to androgen insensitivity, but still the risk is there in adulthood. So the gonads are to be removed.
The more the inner the gonads, the risk of malignancy is more. The superficial gonads, inguinal, it is less. Yes.
If we leave the gonads like that, we need to do regular monitoring of these gonads, whether there's any signs of development of malignancy. So in OSCE, these are the expected questions in CAH and DSD. You should know about Prader staging, the EMS or the external genital scoring, the 17-OHP, the new terminology versus the old, the steroidogenic pathways, questions related to that. What are the metabolites accumulated if there is a block? Stress dose counseling in case of CAH, management of CAH, and genetic counseling. So the potential case scenarios which can be given in OSCE in case of 46X DSDR, 21-hydroxylase deficiency, 11-beta, 3-beta, star or POR. In 46XY, other than this, 5-alpha reductase, complete androgen insensitivity syndrome, and star or POR deficiency. Swire syndrome, Frazier, Denish-Drash syndrome. So you should know about these potential case scenarios. So now let's come to the second question. A 15-day-old child presented in shock, hypoglycemia, hyponatremia, and hyperkalemia. On examination, child had atypical genitalia in the form of clitoral enlargement, gonads not palpable, and hyperpigmentation. Ultrasound showed normal Mullerian structure. So can you answer in the chat box? What is the most likely diagnosis?
CAH.
What are the other causes for this condition if there was no genital ambiguity? So what is the likely diagnosis in this case? So we have evidence of glucocorticoid deficiency in the form of hypoglycemia, shock, and mineralocorticoid deficiency in the form of hyponatremia, hyperkalemia. And ultrasound is showing evidence of normal Mullerian structure, and clinically there's no palpable gonads, and even the ultrasound is not showing any evidence of testes like gonads. So the most likely diagnosis is a virilized female. So this is a case of, presenting as an adrenal crisis. Okay. So what are the other reasons for this adrenal crisis? If there was no genital ambiguity, if the genitals were normal. Yeah. Can I see the chat box?
Investigation, they have written 17-OHP.
Investigation. Yeah. So the other conditions which cause this condition are hypoaldosteronism, pseudo-hypoaldosteronism. This was covered in Rakesh sir's talk, right? Okay.
Yes.
So, and congenital adrenal hypoplasia. Okay. So these are the other conditions which we should think when the genitals are normal looking. So what are the investigations to be done, and how do you do genetic counseling in this case, and how do you treat this condition? So karyotype is the first thing, then serum.
Third box, it's written supplement with fludrocortisone, hydrocortisone treatment. Yeah.
17-OHP, PRA, which is renin levels, testosterone, DHAS, which are the androgens which has to be estimated. So the proof has to be confirmed with synaptin stimulation test. The baseline sometimes can be normal. So always we should do a synaptin stimulation test to confirm whenever there is a doubt. And genetocystoscopy to look in detail about the anatomical abnormality. So how do you do genetic counseling? CAH is autosomal recessive disorder. Again, the percentage of risk is 25% inheritance with each pregnancy. So how do you manage this case? We should manage this adrenal crisis with ABC, IV fluids, bolus normal saline 20 ml per kg, and then maintenance with 1.5 to 2 times the fluid. Hydrocortisone injection 100 milligram per meter square stat with same dose in 4 divided doses. If there is associated hypoglycemia, 2 ml per kg of 25% dextrose. Hyperkalemia should be managed with salbutamol nebulization, K-bind or dextrose insulin infusion, and IV calcium gluconate. And once the child is stable, hydrocortisone should be tapered 50% every day to reach the maintenance dose. So in the newborn, in the initial few days, the requirement will be high. We go up to 20 to 25 milligram per meter square. And fluid record, we need not give when we are giving 100 milligram per meter square. When the dose of hydrocortisone is reduced to 50 milligram per meter square, then we should add fluid cortisone. So also counsel the parents regarding this condition that it is this medicine has to be taken lifelong, and in case of any sickness, the dose has to be doubled or tripled. Coming to the third question, a 16-year-old boy presented with lower limb weakness and delayed puberty. On examination, he had atypical genitalia, hypertension, and hypokalemia. Karyotype is 46XY. What is the most likely diagnosis? You would ask for.
Answer. Hypertension with hypokalemia, delayed puberty, period as boy.
46XY.
XY, yeah.
Hypertension and hypokalemia. So what are the possibilities? So you should look for some pointers in a case of DSD.
Right answer in the box. Yeah.
So the causes of hypertension are 11 beta hydroxylase and 17 alpha hydroxylase. In 11 beta hydroxylase in a male, the genitals will be normal. Whereas in case of 17 alpha hydroxylase deficiency, there will be atypical genitalia. Undervirilization will be there in the form of bifid scrotum or hypospadiasis. So what investigation would you ask for? And what is the cause of hypertension and the antihypertensives of choice? So this is a case of 17 alpha hydroxylase deficiency. The investigation we should ask for karyotype, which has already been done, ultrasound abdomen to look for any persistent Mullerian duct, serum cortisol, gonadotropins, FSH, LH, testosterone, 17 OHP can be low in this condition, and 11 DOC, which is responsible for the hypertension. So deficiency of this enzyme leads to elevated DOC, which acts as a potent mineralocorticoid in the absence of aldosterone, resulting in hypokalemia and hypertension. So the antihypertensives of choice, first is spironolactone. Calcium channel blockers can also be used. So you should always look at some pointers in the diagnosis of DSD. If there's genital asymmetry, most probably we are dealing with a case of ovotesticular DSD. If there is syndactyly, undervirilization, microcephaly, it could be Smith-Lemli-Opitz. If there is evidence of skeletal dysplasia, it could be SOX9 or POR, Antle-Bixer syndrome. If there is associated hypertension, it could be 17 hydroxylase deficiency or 11 beta. Hemihypertrophy in case of WT1 mutation. Renal failure with renal malignancy and atypical genitalia, Dennis-Drash syndrome. With renal dysplasia, Frazier. If there is sex reversal, skeletal abnormalities, gonadal malignancy, it could be Swire syndrome, sex reversal. So coming to the fourth question, are you all with me? Okay.
Yes, go ahead.
15-month-old child brought with ambiguous genitalia, noticed at birth, and abdomen distension noticed since 2 months of age, 2 months. On examination, there was no hyperpigmentation. Mass felt on both sides of the abdomen. There is abdomen distension. Genital examination revealed no palpable gonads. Labioscrotal fusion with pure rugosity. Phallic length of 3 centimeters. Single perineal opening at the base of the phallus. Karyotype XY, 46XY. Proteinuria and renal failure were present. So ultrasound showed evidence of dysgenetic gonads, and MRI showed mass in both the kidneys. So what is the most likely diagnosis?
Yeah, somebody wrote WT1 gene defect. WNT1. Yeah.
Yeah. So with this, we are dealing with the case of Dennis-Drash syndrome with nephropathy, Wilms tumor, and gonadal dysgenesis. So this is due to mutation of WT1, Wilms tumor suppressor gene mutation, and it is inherited as autosomal dominant. So you can get questions related to the old and new terminologies. as match the following. Okay. So now let's see this. So previously female pseudohermaphrodite, and now it's called as 46XX DSD. The word pseudohermaphrodite is not used now. True hermaphrodite, ovo testicular DSD. XX sex reversal is called 46XX testicular DSD. XY sex reversal, 46XY complete gonadal dysgenesis. Mixed gonadal dysgenesis as sex chromosome DSD. And Klinefelter and Turner syndrome as sex chromosome aneuploidy DSD. So coming to the next question, preterm 32-weeker, day 3, brought with clitoral prominence, no gonads, and 17 OHP, 250 nanogram per DL, and ultrasound showed presence of Mullerian structures. So what are the false positive causes of increased 17 OHP level? You should know the interpretation of 17 OHP level, okay? So in a preterm, there could be clitoral prominence because of the edema. Even in case of breech deliveries, you can see the edema of the genitals, okay? So what are the false positive states, in which condition we get high 17 OHP or prematurity? So you should always see gestation age related 17 OHP levels. If the child is sick, if the child is under any form of stress or multivitamin, this can lead to false 17 OHP level. Liquid chromatography mass spectroscopy method is the method of investigation which is required for 17 OHP estimation. So the confirmation tests are synaptin stimulation test and genetic analysis if there is facility. So you should always know about how to interpret 17 OHP level. So always see what values or what units it is represented, 17 OHP level, whether it is in nanogram per ml, nanogram per DL, nanomole per liter. Okay, so please see what units have been used for 17 OHP level and what method of estimation is used for 17 OHP levels. So if the basal is less than 2 nanogram per ml, it is unaffected. And if it's more than 100, then it is a case of classic CH. Stimulated 17 OHP level, if it's less than 10, it is unaffected. And if it's between 10 to 100, it could be a case of non-classic variety of CAH. So next question. A 20-day-old neonate with normal female genitalia presented with shock, hypoglycemia, hyponatremia, hyperkalemia, and hyperpigmentation. Gonads were palpable in the inguinal region. Karyotype 46XY. What is the most likely diagnosis? What are the hormones deficient in this condition? And how do you manage this case? Any answers in the chat box? A 20-day-old neonate, normal female genitalia, 46XY. So we are dealing with gonads are palpable. So it's a case of severe undervirilized male. And we have evidence of glucocorticoid deficiency and mineralocorticoid deficiency and also androgen deficiency. So all three are deficient, right? So what could be the cause? So this is in the initial pathway of the steroidogenesis pathway. The STAR deficiency, steroid acute regulatory protein deficiency, which is the ACTH dependent pathway. So glucocorticoid, mineralocorticoid, and sex steroids are deficient. So we have to replace these glucocorticoids, mineralocorticoids, and sex steroids. I think Dr. Amanna, shall we stop in view of the lack of time?
Yeah, you can continue. You have any other presentation? One more slide is there?
Yeah, one more slide is there.
Yeah, complete it.
Okay. So 8-year-old girl reared as 8-year-old child reared as girl who was operated for an ovarian mass on left side, normal uterus and hypoplastic ovary on the right side, which presented 2 years later with a mass on the right side. So she's pubertal and karyotype 46XY. So we have a 46XY karyotype who is rated as girl. Okay. And genitals are normal. The ovaries are hypoplastic and on one side there was an ovarian mass. So what is the possibility? What is the most likely diagnosis? So something like a sex reversal, right? Complete sex reversal. So we are dealing with the case of Swyer syndrome. 6XY complete gonadal dysgenesis. So So what we should look is, we should look always whenever we are operating on one side, we should always look for dysgenetic ovary on the other side and remove that dysgenetic ovary because the malignancy in these dysgenetic gonads, especially in this presence of Y chromosome, the risk of malignancy is very high. So the early removal of this dysgenetic gonads has to be taken. Thank you.
Thank you, Dr. Vani, and you have made justice to the OSCE. 50 to 60% of OSCE will be dead easy, and 20 to 30% will be little tough, and around 10% it's unreachable. That is the pattern of DNB. So we are the examiner for the DNB, and our hospital is a center. So now, without wasting much time, we'll go at least within 2 to 3 minutes. I will cover what are the questions asked theory for DNB and MD. So, Vani, if you can stop sharing, I can share my screen.
I have already stopped.
Yeah, thank you very much. So without wasting much time, so most of the questions asked in theory are approach to ambiguous genitalia. Now this terminology is replaced by DSD. So outline human sex differentiation, provide an outline approach of infant with DSD, explain synthesis of steroids. This is a commonly asked question from the basic sciences. So you should be perfect in the steroidogenetic pathway, genesis pathway. Discuss approach to child with DSD. Karyotype abnormalities, clinical features, management of true hermaphroditism. Describe diagnostic approach in 2-year child with DSD. DSD definition you already know. So that is discordance between the phenotype, the genetic sex, and external genitalia. These three are important. So internal sex, external genitalia, and your genetic sex. These three should be same. So then nursery evaluation of newborn with suspected DSD by history, physical examination, diagnosis. Issues in management of DSD. So they are asking for common all the problems 46XY DSD and 46XX DSD. So newer questions can come approach to 46XX DSD or 46XY DSD. Like that. So congenital adrenal hyperplasia, management of CAH, salt losing CAH or adrenal crisis. They can give the scenario and ask the questions. Outline the biochemical consequences, defects in 21 hydroxylase deficiency and its management. So you should write the management at crisis, and when child, how will you follow up of the patient? Already we have mentioned. Look for the 17 OHP, testosterone, blood pressure. Look for the pivotal changes, bone age. This is how you should do the follow-up. Clinical features and management of classical congenital hyperplasia, clinical features of CAH, management of CAH, diagnosis and prevention of congenital adrenal hyperplasia. This is also commonly asked question. So how to write an answer? Just I wanted to tell in brief within a minute. So first, write to the specific and to be focused to the question. They ask management of CAH, write only management. That includes the investigation and treatment. And treatment part, you should write also the genetic counseling and follow-up. So like that. So any other questions are welcome. So I request Dr. Shaila Bhattacharya Madam, any suggestions or inputs to the forum?
No, it was an excellent session. Everybody did justice, including the presenters. Great session. Thank you.
Yeah. Thank you very much, madam. Thank you, Mayank, for your troubleshooting. Because second presentation, both madam and the student presentations were a little difficult. In spite of her busy schedule, Sudhara madam has given excellent discussion how to approach DSD with history and examination. We thank both the postgraduates, Dr. Panda and Dr. Madhuri. And first discussion was in detail, presentation by Dr. Rakesh sir. So we thank you one and all. Thank you very much. I thank Vani in spite of her URI presented excellent. Thank you, madam. Ankit, we can end.
Yeah, thank you so much, sir, for your time.
Yeah. Thank you one and all.